Welcome to the Access podcast, hosted by the Access to Medicine Foundation. My name is Iyer, and I lead the independent Access to Medicine Foundation. We're based in the Netherlands, and our mission is to bridge healthcare equity by incentivizing the pharmaceutical industry to do more for people living in low and middle income countries. Today's reality is that billions of people worldwide still do not have access to essential healthcare services and products that they need to treat simple conditions and chronic conditions in the world. And this is an unacceptable reality that we need to change. I'm joined today by a leader in access to medicine who has spent decades working on this field. Joseph Saba is the CEO and founder of Axios International, an organization that has been working with some of the largest pharmaceutical companies on bridging gaps in access to medicine and delivering access programs globally for a range of different conditions. Joseph, welcome.
Thank you. Glad to be here.
So tell me a little bit about your background. We know you've spent multiple decades in the access space, all the way from HIV care till today. You've written a book on how geopolitics have shaped access to medicine. Tell me a little bit about your journey and why access to medicine is absolutely important today.
Yes, thank you. Thank you, Jay. I am an infectious disease physician by training. And when I started, that was back in the early 90s and late 80s, HIV was the major infectious disease at the time. And I was treating patients and not able to save them because we had no medicine. And then the Africa epidemic of HIV started ramping up early 90s. So I felt we needed to do more about it. And this is when I joined the World Health Organization to try to do research, try to understand how we can find a solution. We weren't at Access at the time. And in 1996, the protease inhibitors and antiretrovirals came, and suddenly we had solution. And at that time, we started, I joined UNAIDS, and the question was, okay, so now we have the solution. What do we do? How do we get it to the African continent? And this is where we started piloting. I was tasked to negotiate with the pharmaceutical companies to try to find a solution. And that's how my journey with Access started in WHO and UNAIDS. Then I felt that was my mission. Right. I dropped the clinical work and it became my battle.
So in the Access to Medicine Foundation for almost 20 years, we've been measuring the progress made by the pharmaceutical industry.
Yeah.
The progress has been very gradual over time. We've actually demonstrated that in a biennial report called the Access to Medicine Index, which you're familiar with. And the pharmaceutical industry uses the Access to Medicine Index as a way to benchmark their performance against the rest of the industry. We identify opportunities in there that they use to act on and partner with organizations. In the last Access to Medicine Index that we published last year, we found that actually a slowing down in progress. And that is probably exacerbated now by some of the geopolitical changes that are happening worldwide. But as someone who's been working with the pharmaceutical industry now for, decades, what have you observed? Have you observed that progress? Tell us a bit about what's working in your interactions with the companies and what you've managed to set up.
Yeah, I mean, we started 25 years ago. So the discussions, and at that time, there was a dichotomy, very clear dichotomy. Innovative products were in the West, in wealthy countries, and people needed to wait until the patents expired, and we had generics to make it available in low-income country. It was one price for everybody. There was no differential pricing or anything. This was broken with HIV, this paradigm. And that's how we got into antiretrovirals worldwide, including in low-income countries. It became generic afterward. But the companies felt that it was feasible and really played the game. And this moved from HIV product to cancer, to all these chronic diseases that required, I would say, innovative medicine that were costly. So they played the game. Now you could feel that in the industry, there is a shift toward more and more rare diseases that are even more expensive than the others. Coupled with the geopolitics, you could feel that the industries are saying, can we continue doing the same as before? And if not, then what do we do? And I think there is a lack of clarity. It looks like we're coming to the end of a cycle and beginning of another cycle. And to talk about access to medicine index, I think if we didn't have it, we should invent it, because it was really extremely important for us working with the companies and trying to show the companies what the solutions are. The index helped us a lot in getting that, I would say, political will and policy decision at the company's level to be able to execute these solutions.
Right.
So it was really extremely helpful.
Yeah.
I could feel it from the other side.
Yeah. And over the years, you've worked with almost all the large companies in the Access to Medicine Index. We've also identified that most of access, especially for chronic diseases, is really driven by patient assistance programs in countries.
Yes.
Many of which you've been instrumental in helping the companies to set up, in partnering with governments, partnering with implementing organizations in the countries itself. Maybe tell us a bit about what works, what doesn't work. Give maybe a couple of examples from the industry on unusual partnerships that actually has driven access in longer term in the countries itself.
Yes, I mean, what works and what doesn't work has evolved over time. I mean, when we started, of course, the companies were like, okay, let's donate the product. And we worked with many companies on donations, and they were very helpful for the patients at the time. Also, what we found is, I mean, I can give some examples. In cancer, the first program we worked on was the Gleevec International Patient Assistance Program that Novartis did. We had all the antiretrovirals, and we could see that the fact that you have treatment improved diagnosis of patients. Because otherwise, if you don't have treatment, why do you bother about diagnosis?
It becomes a death sentence.
Exactly. It's like, why don't bother me with that? So we had an improvement of the healthcare infrastructure, because that was always the debate, is we need to have the healthcare infrastructure to be able to make available the treatment. No, you need to have the treatment, and don't worry, everything else will come around it. And that is the philosophy that we worked on. Progressively, of course, with the donations, they are finite. They are not sustainable for the company, and at the end of the cycle, it doesn't work. So, and also we got confronted with the reality, probably less in low-income countries, more in the middle-income countries, where you had the rich people who had access, and the poor people who had access to the donation, but the middle class was not poor enough to get the donation and not rich enough to get the product. So this is where the evolution started, and we said, so we need to find a way where maybe this middle class doesn't have to pay the price of the medicine as it is, but like get some kind of help to afford these medicines without having access to the donation. And that's how we started with more sophisticated, I would say, access strategies and program that allowed that middle class to get these programs. And that made the programs actually much more sustainable. And then it became part of the business model of the companies. And with the help of the index, I mean, your help as the foundation, it became part of, they all came to us and said, we need to do an access program.
Right.
It wasn't like before. We had to spend hours and days discussing and explaining why it's important to do an access program, etc. It became now, no, we want to do an access program, so what do you recommend?
And they know what it looks like, because there are examples out there that have been working, have
Absolutely.
built infrastructure, have delivered care longer term.
Yes.
So that has actually been a great demonstration. With good practices, you demonstrate to the industry what works and what doesn't.
Exactly. And And with these innovative program, looking at the middle class, trying to work on what the patient needs. So these became more individualized, I would say, access programs that help the patients, and that's how it started, and it has evolved. For instance, we started many programs, in Asia, in the Middle East, in Latin America, in Africa. And then what we found is, okay, well, where are the patients? So you start with the number of patients, and the others are not diagnosed. So we need to find a way to give them more access to diagnosis, or at least to inform them that we need access to diagnosis. And then also we found that with these programs, and that's what happened, also the companies came and say, your duration of treatment, because these are chronic treatments, so the duration of treatment was much longer than even with those who have insurance or they are reimbursed. Well, because we do follow the patients and make sure that they are taking their products, we started doing adherence program.
Right.
So suddenly it became everything that could help the patient get the full course of treatment became part of that broader, I would say, access. And the referral is extremely important. And we were talking about access to program. I can give you an example of a program we did in Africa, actually in Ethiopia, with AstraZeneca, related to breast cancer. And at the time, the Minister of Health, who is now the head of WHO, told us, it's not my priority. It's very interesting program. So go do it, and please keep the ministry informed about it, which makes a lot of sense. And we improved the diagnosis in Tikur Ambessa, which is the reference hospital. But the patients were everywhere in rural Ethiopia and had no access to diagnosis and ignored it. So the cases were coming very, very late. And the average, we did some publication, the average duration between the suspicion and actually getting the diagnosis was 8 months. I mean, in 8 months, a lot of things could happen in breast cancer. So we improved that, but then we said, okay, so where are the patients? Again, where do they come back from? And they were in the regional hospital who had no means to do that kind of diagnosis. So we started saying, if you have a suspicion, refer them to the company. Just call that number. We made the number, which was a patient association, just taking care of these patients.
And with that number alone, what kind of result did you get?
Tenfold.
Tenfold increase.
Tenfold increase. From Tikur Ambessa used to look after like 300 women. They became 3,000 women in a year. So there are ways to do these aspects without having to cost. It was a number, I mean, you still need to have somebody answering the phone, but that's it.
But at the end of it, all of this was built, a tenfold increase was built around the willingness for a company to say, I'm going to bring my product in there.
Yes.
At an affordable rate.
And register
it. The willingness of a government to invest and say, sure, do this. It's not one of my top highest burden diseases. I don't actually know whether that's the case or not, but come in and
exactly
help the situation. An entire infrastructure system was built around that program.
And that availability
of treatment. And I think that's the model that we're looking at, that patient assistance programs may not look like the sustainable solution, but everything around infrastructure development, policy, reimbursement all gets built around that and can help a lot of patients worldwide.
Absolutely. And it ended up with the breast cancer policy by the Ministry of Health. So,
well, it's impressive. Tell me a little bit more about how have the attitudes and the investments from governments in these countries evolved over time? Because I think one of the biggest arguments we often have is the governments do not invest enough in healthcare. Their budgets are stretched between different priorities. And at the end, healthcare budgets are very small. At the end, you still need someone to pay for infrastructure development, for treatment, for management and care, for diseases, and also to keep the hospitals running in a safe and effective way. So how has the financing around this actually evolved over time, and what's the government's attitudes in all the different countries you've worked in?
I think it has been diverse depending on the governments. There are governments who actually geared up to it, not by necessarily increasing financing, but yes, they did put some more efforts. And in low-income countries, the GDP is so low that even if you increase the spending, you have so many priorities with very little money that it's not always easy to increase it. But at least move with policies, allow initiatives, including private initiatives, to improve the infrastructure. And that's what we found with the donations. Even if the government didn't really invest actually dollars, by allowing some policies and allowing products that are not necessarily registered to enter the country with some control, of course, and giving waivers, etc., they did improve the infrastructure without spending necessarily dollars.
Right. So there are lots of enabling conditions that the government can create that adds on to the dollars.
Yes,
it's
to not only yes and no. You put money, don't put money. It is also the creating the enabling environment for local and private initiative, NGO initiatives to actually increase the availability and accessibility of the product.
So what are some of the most important enabling conditions that you believe that governments and local players, because I think there are also charities that are getting involved.
Of course.
And in delivering access, there are also implementing NGOs that are getting involved. But what are some of those enabling conditions that make a difference between a successful program versus one that doesn't take off and make as much impact in patient reach?
I mean, there are many ways. One is, as I said, the policies, like what happened in Ethiopia, which was extremely favorable for breast cancer in general and cancer as well. The other is the issue related to registration. Registration in many of these countries take years. For a product that is already approved by FDA and the European EMEA, and they're using the same file. So you need to do registration, that's great. But let us try to get the product to the patients before. We don't want to wait so many months and years in the registration. So that is a stumbling block that is going to be more and more important as now the innovation is going toward rare diseases where maybe the companies will feel it's not worth it registering because I have 10 patients in the country. So registration is really an issue, and I'm not suggesting we should not register, but we just need to balance that act and allow exceptions in the name of accessibility.
So, I mean, there are countries that are right now working quite closely together to accelerate registrations.
Yes.
And I think for companies, those become very favorable conditions and important markets to register their products. But in certain countries, there is no product available because of the disincentive in saying registration systems are just not in place, or it takes a long time, and the regulatory infrastructure is not there. So we do nothing about it. And that's the area where you're saying if you partner with the government and the local players, you can potentially get import waivers and other ways to make sure the product reaches the patients, however few patients or many patients you actually have in these countries itself. So there are ways around it while waiting for the registration systems to actually get better and improve.
Absolutely. And there is one other aspect that is important is in now many countries, not all of them, but many countries, you have a portion of the population that is covered. Either by Social Security, by private insurance, whatever it is. And then nothing happens with the rest of the population, which is usually 80-90% of the population. And the companies focus on the registration, because that's where they make the money. And what about the 90%? What do we do with them? And here also there is a role for the government to play. And I can give you another example in the Middle East, actually, in the UAE. Now, the UAE is a wealthy country. It's not, but there are many expats that are not necessarily covered by the government and blue collars, etc. They have basic insurance, but not access to these innovative products. So when we started working with them, the government became interested and said, yeah, that's good to do this program. And it got to the level where they told the companies, if you want to get reimbursement, then you need to do this access program for the people that are not covered, versus just focus on my budget, this my budget, give me a discount. No, let's also focus on the 80, 90, 60%, whatever it is, population that is not covered, and incentivize the companies and push the companies to actually do this kind of program.
So going to the point on incentivizing, push, try to move companies. In the Access to Medicine Index, we also rank companies, and there are some companies that are really difficult to convince them that you need to make that big transformative change to make that level of impact for 80% of the world's population living in low-income countries. So how do you think we can leverage the successes that are there? How can we change the notion of the level of risk that they will face in countries, the notion that infrastructure is not available? I will wait until infrastructure is actually available and financing is available and then do something. How can we change that notion?
This is an excuse. This is not
a reason.
This is not a reason. I would say carrot and stick. So the carrot is that we need to have sustainable programs, and that's what we do. That's what we always focus on, the sustainability of the program, and we even sometimes tell the companies that are overly generous is you need to manage that, because in 2 years you're going to come to us and say, I want to shut down this program. It's not, or maybe not you, because you'll get promoted and somebody else will come and say, I want to shut down this program because it's not sustainable. So we need to work on the sustainability. That would be the carrot from my perspective. The stick is, as I said, is you don't get reimbursed if you don't help the rest of the population.
So when you think about what the pharmaceutical industry can do more, another topic that comes up often is innovative products or new products, right, to solve unmet medical need. Often doesn't, it's prioritized for the US and Europe.
Yes.
Infectious diseases and neglected tropical diseases, they tend to be driven a lot by aid budgets and product development partnerships. So those tend to be made available in low and middle income countries. But when you think of all the new innovations that are coming from the industry,
yes,
how do we make sure that these innovations are reaching patients globally? We've identified that one way, which is early access planning. When a product is already in phase 2, shown effectiveness or shown safety studies, that's the moment to start planning early, partnering up with players in the public sector and the private sector on the ground to really develop supply chains, affordability, start planning the registration dossiers or alternative methods to get products into countries itself. But we've also found out that in terms of clinical studies, a lot of countries only receive treatment, receive a particular product after a clinical trial is actually run in these countries. No clinical trial, no infrastructure development, no registration, no product. And they have to wait either years or never get access to these particular treatment. So how do we convince companies to plan early for access, be more inclusive in terms of running clinical studies in more countries, and eventually scale up that access to these innovative treatments globally?
Well, I would say the phase 3 studies that are related to looking after the efficacy, the design of these research are meant to really show that the medication is effective. So they will probably just focus on the countries where they want to prove it, and that we go back to US and Europe, and maybe Australia, Japan. I
Right.
mean, these kind of countries. But after you have expanded access, where you can see what's happening in these population, etc., you have a mean to do that even before any registration is done. And once it is registered, then we continue that expanded access in terms of programs without being registered, getting waivers from the ministry, partnering with the ministries to make sure that these products are accessible, especially that many of these innovations are life-saving products. They are improving life expectancy. So it's not... so there are ways where the research becomes important, and as we were saying, like for the donation, it's going to build the infrastructure. And I think without necessarily having to pay for the infrastructure, by making their product available at that early stage, they are going to improve, which later would lead longer term to a market for them.
Right.
But so we should stop focusing on this short-term gain only. They're accountable for their shareholders, but we also need to build for the long term without necessarily, putting it as antagonistic to short term. You see,
Right. You can do it.
it's not going to cost you so much to do an expanded access.
No. And I think that if you can really see the benefits. And recently we've noticed that a lot of members in the industry, also investors, they do prioritize patient reach as an important metric and also an important measure of the impact of a pharmaceutical companies.
And we have a lot to learn from that.
We have a lot to learn from that.
We continue to learn even after 25 years by working with the patients, seeing how the patients behave, and all of that, continuously improving our method to ensure that they take their full course of treatment. So no question.
So a large part of access globally is driven by funding from, aid budgets, philanthropy, and that has really driven access to HIV treatments, malaria, HIV globally. And today we are in your book, A World Divided, a quest for better healthcare beyond geopolitics.
Yes, I'm divided because this is what I am aiming for, yes.
Yeah, but we're actually sitting today in a bit of a juncture in geopolitics where the world is divided.
Yes.
United in the fact that we all want to see better healthcare globally, but divided in terms of the politics and the geopolitics behind it. We've seen huge changes in terms of aid budgets being cut. That has affected patients globally, practitioners globally. Programs are being stopped. What kind of impact will this have on the pharmaceutical industry? Is this just another hurdle, or is this going to be a major setback for all the progress we've seen so far?
I mean, it is interesting you say that because the logical answer is that they need to step in, but step in with what? You see, when you look at the portfolio of the companies, all of them are moving into research related to rare diseases where you only have handful of patients in every country, very specialized medicine, very expensive products. So, but how do you handle the division, this division in the world, with where the volume that you need is across countries? It's no longer by country the way it was in the past. So you have to globalize, because otherwise you don't have much use for your product that you are doing. So, and I don't think they figured it out yet. I think they're still looking in their business model, and I could feel that that's what we were talking about, is that it looks like a turning point now, where they don't know what to do with access in their model, because they don't know what the business model is going to be. So there is uncertainty already in the industry related to the way the science is evolving. Uh, at the same time, you are in a world that is undivided, which goes the opposite direction to what their portfolio is going. I am an eternal believer on globalization. I think these are setbacks that are transitional. I think the boat has sailed with internet, with all social media, etc. Where the world is globalized in a way or another, and we need to keep capitalizing on that to and break some of these hurdles between countries. The registration is one of them, the policies, all of that, to be able to allow more access to the patients.
Joseph, are you optimistic about the future? Do you think that we can recover from the current division that the world is facing and the feeling of helplessness that everyone is facing today in order to deliver access to medicine for the patients that are waiting for access?
I am optimistic. I do believe in globalization. I did mention that in my book. I think we will adapt. I think the boat has sailed. We're not going back on globalization with the internet, the social media, and all of that. There are some hurdles. There are these country barriers that are increasing now, even in developed countries, but that we will need to tear up, because for health and the way the company portfolio and science is going, with a handful of patients for these rare diseases, you can't just do things in the country. You have to do things across countries. So I am optimistic. There will be some hurdles. We will work on that. I think there will be financing, maybe not the same way, maybe in a different way. I think with all these, I would say, cuts in international aid and all of that, maybe it will energize the country to go into more private. Let's remember now, when we discuss with people and say we need to build infrastructure, they want to build hospitals. We are in the area of chronic diseases. So you don't need the hospital for the chronic disease. How long do you stay in the hospital for a chronic disease? You go to see the doctor. You stay what, 1 hour?
Yeah, ideally.
And the rest you're sitting there. Ideally, yes. Sometimes you spend a day waiting for the doctor, but basically most of your treatment is actually at home. So we need to build a certain infrastructure around the hospital without dropping the hospital, to actually follow the patients and ensuring that the patients are getting their treatments wherever they are. And that's a different concept that doesn't cost as much as a hospital. The hospital is an expensive venture. So we need also to shift our mindset in terms of what we mean by infrastructure, now that we're focusing so much on chronic diseases. And that also means less money, more private initiative, because it's across the society now. It's no longer one specialized center, and that is a change. So maybe it will move that in a different way. And I am an eternal believer. Homo sapiens is adaptable. We have been adapting for 1 million years, so I think we will continue.
And it's down to human action, right? So if a pharmaceutical industry leader signals the willingness to make products available early,
yes,
willingness to partner on this, works with existing networks, looks carefully at the programs that are working, aims to expand that, builds around those networks, I think we can really bridge a lot of gaps in access.
Absolutely.
So Absolutely. that willingness shouldn't change just because the politics are coming in the way.
Exactly. And they will have to, because otherwise there's no use of their new products.
No.
What for? They just need to realize, again, as I said, we are now at the end of a cycle, starting a new one, and we have work to do. And if we talk again about the index, which has been extremely helpful, I have also confidence that the index will adapt to allow that incentive
Yeah.
for the companies and for all of the players to work together to change that paradigm.
We have tools like the Access to Medicine Index as a roadmap. There are many resources available, including real life examples of what has worked and the increases in patient reach that has been achieved by existing programs. What approaches and strategies do you think will define the next decade in access to medicine? Can you share a little bit of your reflections looking ahead at the future?
Yes, I think looking ahead, when we look at access to medicine, we're talking about access to innovative products. Now, access to existing products is still not optimal. We need to move. But in my opinion, with the patents dropping and access to generics, we will see more. But even some of them are still very expensive, and you still need to have programs. And we started doing some programs with, the biosimilars and all of that, because you still need these access programs. So there is a reshaping of this. I feel for the next decade, also with what happened in terms of public funding and international aid, I think there should be more reliance on private initiative. I mean, when we look at the other sectors that are driven by the private sector, we could see that that you have a huge progress. And I'm not suggesting it's a public good. Healthcare is a public good, but it doesn't have to be exclusively driven by the public sector.
Right.
And maybe this is where the opportunity is to have it driven also by the private sector, with and the industry, the companies, the pharmaceutical companies are at the center of that private initiative. So they can't shy away from it. I mean, they will have to. So I do believe that's where the focus is going to be, to improve access, and this is at least our next crusade.
Right. There's a trend that we've observed where we're starting to see many pharmaceutical companies already exiting infectious disease research. Some companies have even stopped producing basic things like antibiotics in global markets. This is obviously, infectious diseases still kills people all around the world. And we do have an arsenal of products that work really well. This has been in markets for years. Is this cause to worry when you're thinking about ensuring safe access to medicine for people living in low-income countries?
I mean, in the short term, yes, it is. And we need to look into it and find different incentive. But fundamentally, on the long run, I am an infectious disease, and I trained in Claude Bernard Hospital, which is a hospital that was built in 1880 for the 1900 exhibition in Paris. And they wanted to close it 3 times because they said, now with the antibiotic, we don't need infectious diseases. And they couldn't until 1989. 100 years later, they closed it. We're not going to get out of the infectious diseases. The COVID pandemic reminded us that. So sooner or later, they will have to step up the efforts, and even in rich countries, they will have to step up the effort, because, as you said, these resistance that are in low-income countries now are going to spill to high-income countries. So we're not going to get away from infectious diseases. It's short-sighted to stop it now. But I mean, these are the economic imperatives. But but on the long run, there is no way out. Infectious diseases are there for 4 billion years, and they will not go away.
And there are going to be new emerging threats
New
that are coming
emerging
forward.
threats, more resistance strains that you have to deal with, and there will be more research on it, no question. So I am optimistic.
Joseph, if you can give one message to the pharmaceutical industry right now in this critical juncture that we're sitting in the world, let's say you're talking to all the big pharmaceutical company CEOs right now, what would that message be?
My message to the CEO is that despite all what's happening now, you need to become more global than ever before and focus on the globalization, given where your portfolio is going, where your science is going. And you need to be able to work with different stakeholders and governments to drop these country barriers that we talked about and improve the policy. And my advice is to be proactive in this as you're looking for your new business model related to these diseases. You need to be proactive of it. Don't wait to be pushed the way it happened in the past, because sooner or later you're going to be pushed. So you might as well be proactive from the beginning. That would be my message.
Now, we've had an excellent discussion today on the barriers for access, how to scale up access to medicine in low and middle income countries. We've tackled some of the reasons and excuses, the opinions that are brought into the table when you're talking about expanding access to medicine. But I hope that we've also managed to inform listeners that access to medicine, improving health equity worldwide, is a fundamental human right. There are great examples out there on things that we as a society, working with the pharmaceutical industry, working with governments, working with patients, have managed to achieve in bridging that gap. And right now, despite all that's what's happening in the world, we need to do much more, and we can do it with a sense of adaptability, with a great vision for improving access and really bridging that gap. Thank you, Joseph, for joining us today. A big thank you for sharing your valuable insights, for the incredible work and your leadership in driving this agenda today.
Thank you. Thank you for hosting me.